and happy Nursing Week. Thank you for joining us today for this Nursing Week webinar event entitled Artificial Intelligence in Nursing, Innovation, Impact, and Accountability. Today we will have a panel discussion featuring experts in nursing informatics, data science, and law to explore the impact and considerations of integrating AI into nursing practice. My name is Terry Irwin, and I'm the Executive Vice President and Chief Nursing Executive at Trillium Health Partners. I'd like to begin with a land acknowledgement. I wish to acknowledge this land on which we operate. For thousands of years, it has been the traditional land of the Huron-Wendat and the Seneca and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. By acknowledging the land, we acknowledge our responsibilities in sharing this land and to the Indigenous people who have been the traditional caretakers of this land. At this time, I invite you to reflect on your relationship to this land with Indigenous peoples and with your broader understanding of reconciliation as it relates to your role in healthcare and specifically nursing. Thank you so much, and now I'll turn it over to Robin Stremler.
Thank you, Terry. Hi, everyone. My name is Robin Stremler, and I'm the Dean of the Lawrence Bloomberg Faculty of Nursing at the University of Toronto. Today's event is a webinar, meaning that only the panelists and moderators can turn on their audio and video. If you would like to turn on live captioning, you can do so by clicking on Show Caption that you should see at the bottom of your screen, and then follow the instructions as prompted. A note that this event is being recorded and will be posted online later this week on the TAHSN website. And that link to the TAHSN website is now in the chat for you. So over to our moderator, Bren Cardiff.
Thank you so much, Robin, and good afternoon, everyone. My name is Bren Cardiff. I'm the Chief Nursing Informatics Officer at the Hospital for Sick Children. I'm also a project investigator with the Sick Kids Research Institute and adjunct lecturer at the Faculty of Nursing at U of T. I'm really excited to be amongst three really great thought leaders in the space of AI today, and here as your host for this panel today. Before we start, I do want to say Happy Nursing Week to all of my nurse colleagues on the line, and a big thank you to everyone who submitted some questions of interest as you registered for this event. We all thought they were very thoughtful and great questions, and we look forward to answering many of them today. And so I will be going through introductions of each of the panelists as I ask them targeted questions related to the expertise that they bring in the space of AI and nursing. And so to kick us off, our first question of the day is going to go to Azi Asadi. And so, Azzy, if you can come off of mute with us. I'll just take a moment to introduce Azzy. Azzy is a human factors engineer here at Sick Kids and sits on our AI management committee. She has an academic role as the clinical lead for Lawson Labs, which is a multi-D research lab that's focused on systems, data science, and machine learning in pediatric critical care environments. She's also an active pediatric nurse practitioner in our cardiac critical care unit at Sick Kids and is an adjunct lecturer at the Faculty of Nursing at U of T. Welcome, Azzy.
Thanks, Bren. Good afternoon, everybody.
Azzy, our first question to you is, as a human factors engineer, can you please speak to some of the broader considerations of integrating data-driven AI tools in hospital systems and our workflows?
Yeah, it's a great question, Bren. So more and more as we make advances in medicine, healthcare, and even just basic science that helps us understand our physiologies more and more, the complexity of diseases that we care for within the healthcare system, not just in hospitals, but more broadly, will continue to increase. And it has exponentially grown over the last few years. And so with all of that, we still are the clinicians who have to maintain a knowledge that is in keeping with what the current state of knowledge and understanding is of medicine broadly, and be able to integrate these much finer, larger data points for each patient as we make treatment decision, management decisions, and so on. And I'll be honest, with the increasing number of patients and the complexity of each one as we go sort of forward in time, it is harder and harder for us to be able to make personalized decisions and make decisions that are precisely tailored to a specific patient based on the latest and greatest data and science that's available. And so the use of decision support tools that would help us understand our patients better, understand our data more clearly, and be able to make better decisions based on all of these becomes more and more prudent now, and especially as we move further ahead. You know, a couple interesting facts. About 30% of the care that we provide, particularly in pediatrics, is actually not based on hardcore evidence. If you ask anyone who works in the pediatric space, they can't tell you very many randomized control trials that are large, multi-centered. And so a lot of these are gestalt or general practice behaviors that we have as we treat patients. 10% of the care we provide actually can be harmful. And if you think about adverse events, somewhere between 6 and 17% of the adverse events that are seen in hospital environments are actually diagnostic errors. And 10% of these errors can actually lead to harm. So these are some stats, numbers that reflect human error as it relates to how we manage patients, and leveraging data in a really efficient, constructive way that recognizes limits of human cognition. People make decisions differently, whether they've slept and have had a good night's sleep versus if they're sleep deprived or have had multiple things going on in the background. So these things are specific features of our human brain. And so acknowledging these specific attributes and be able to leverage technology, take these considerations into account, and then tailor tools that would help us make decisions and provide better care becomes fundamental and central to how we practice medicine moving forward.
That's great, Ezzy. Thanks so much for that reflection. I'll take a minute now to introduce my colleague, Kama Kalia. Kama is the Director of Health Information and Informatics Solutions at Trillium Health Partner. She brings nearly 20 years of nursing experience and a wealth of expertise as a systems leader with a diverse background. Her experience in AI emerges from hands-on deployment, evaluation, and governance across clinical and operational domains. She's led several quality improvement initiatives and digital health implementations. She's also an adjunct assistant professor with the Faculty of Health Sciences at the University of Western Ontario, and an adjunct clinical appointment at U of T's Lawrence Bloomberg Faculty of Nursing. Welcome, Kama.
Well, thank you so much, Bren, and happy Nursing Week all.
Kama, can you please speak to the importance of the nursing voice in driving design and adoption of digital solutions and the competencies nurses need to practice safely in an AI-enabled environment?
Thanks, Bren. I really thought about this question in advance of today and wanted to ground it in something that would maybe be relatable to others. And so if I'm going to design an ICU or a medicine unit without an end user, it may look really nice. The architecture might be sound, but it may not be fully functional. And there's a risk that we could place for not only our patients, but for our staff, our peers. And so one of the things I want to talk about today is the AI pipeline. And for those that are not familiar with the AI pipeline, it's basically the end-to-end cycle from AI input to AI output. And nurses should be engaged at every single level, every single stage, as essential architects. And so playing a role in design for patient safety, clinical accuracy, health equity, and for workload, and of course, workflow. And so when I think about the pipeline, I actually go before what's traditionally known as the pipeline. to answer your question, Bren, because I think about how nurses are consistently connected to data, and our inputs create inputs of data into our systems. And so if we think about the raw data, this is coming from assessments and the care we provide from standards of care. And so it's paramount that we design systems by which we collect this information. That could be equipment to, again, what is discreetly documented, narrative, whether it's with AI or without. And then to enter into the AI pipeline, it's thinking about, are nurses engaged in identifying the problem of what we're actually going to focus on? And so what I mean by that, and it's a common question my team will ask, is what's the problem we're trying to solve? Otherwise, you might be designing for the wrong solution for the problem that's been identified. And so asking nurses to be engaged not only in problem identification and define, but then also in understanding the data sources and prep, like the data prep as it's described in the AI pipeline. What does that mean? Is that, do we trust the data? Is it actually reflective of our practice, of our reality? And then followed by the model development. And so did we actually answer the use case, the problem? And what does that output look like? What will nurses actually see? Validation and testing being the next piece, which includes looking at addressing biases, which we'll talk about today. Deployment, meaning the workflow integration. And then lastly, monitoring and governance. What is the performance of the model? The nurse is essential in every step of the way to, again, have clinical accuracy and patient safety at the forefront. So when I think about competencies, Bren, I think about so many, but so I'm going to have to reduce this list for today, and I'm sure we're going to talk about more. But one essential one is critical thinking. Advancements in technology do not replace clinical judgment. They inform decision making. Another is, of course, keeping the patient at the center. And that means understanding our patient's needs, thinking about cultural considerations, and more. Another one, which is why maybe you've logged into this call today, is digital literacy, data literacy. And I'm not talking about the jargon. I'm talking about what it really means to nursing practice. I mentioned raw data. The next one is understanding data quality and the importance that nurses play in, again, not only documenting, but documenting consistently and to reflect practice. Privacy and ethics. And then my last one is quality improvement competencies as it relates to patient safety. So what are the safeguards that we need to think about in every step of the AI pipeline?
Thanks so much, Kama. I will just reflect on, as he opened up talking about that importance of the nurse understanding their work, the complexity of the children that they care for. And then you reinforced really the reason we bring in nurses throughout that pipeline, even up front to the AI pipeline, because they do know the work, they do know the complexity of the environment that they work in, and that really reinforcing them as architects. I love that concept, comma, within the pipeline is really a leading practice to stick to. So thanks so much. You talked a little bit about competencies around risk. And so this is where I'm going to introduce our third panelist for today. This is Melanie DeWeet. Melanie is the Vice President of Strategy, Partnerships, and Risk, Chief Legal Officer at Unity Health Toronto. Melanie has been a lawyer working on behalf of hospitals and healthcare for over 20 years. She received her law degree at U of T and completed a master's in public health at Johns Hopkins University. Melanie recently served as chair of the Toronto Academic Health Sciences Network Legal Table and also teaches health law and risk management within health administration and patient safety graduate programs at the Institute of Health Policy Management and Evaluation at the University of Toronto. She happens to, in her spare time, also be currently getting her PhD in AI. So very impressive, Melanie. Welcome to the table.
Thanks so much for having me.
Melanie, AI has been a strategic priority at Unity Health Toronto since 2019, where you are currently the VP of Strategy, Partnership and Risk and Chief Legal Officer. Can you share with the audience today how you use risk management to ensure responsible use of AI?
Yeah, thanks. So I think the first thing to point out probably is that, in healthcare as a sector, we've been doing risk management for decades, and we're actually really good at it. We do it really well with relatively fewer resources when you look at other sectors. And in healthcare, in the banking sector, they have like armies of risk managers. And in healthcare, it's like everyone is a risk manager, right? So every clinician, whether you're aware of it or not, you're trained to scan the environment for risk, communicate about it, assess it, right? Like how bad is this? And then react to it in a proportionate way to mitigate that risk down to an acceptable level. Like it's really woven into the clinician fabric. And so that helps us a lot, I think, when it comes to dealing with AI and adjusting to it, especially because right now in the early days, like there's not enough regulation. We can't look to a standard. The college hasn't put anything out that tells us what to do at a really granular level. So going back to those key principles of risk management is really key to develop and deploy responsible AI right now. And if we think about, risk management in terms of its essential underpinnings, it's really just this ongoing process of like scanning the environment for risks. So trying to identify new risks, then assess them in terms of, how likely is this to happen? And if it happens, how bad is it going to be? And then manage the risk down to an acceptable level. And so that's essentially what we do at Unity when it comes to AI. We have these set risk categories, and we all, probably have very similar risk categories. So clinical risks, people risks, reputational, legal, strategic, risks to our infrastructure. And then as we're developing or procuring and deploying AI, we're doing that with a bit of a risk tolerance in mind. So, at Unity, we say when it comes to people, whether it's our patients or our care teams, you got to be in the green. We got to be low risk. Same thing when it comes to reputational risk, because we really see that as a proxy for trust. And trust is just so essential when it comes to healthcare in general, but all the more so for AI. Like we really can't afford to get it wrong. So we take this approach of just using that risk management framework when we are designing, procuring, like across the life cycles, testing, deploying, and then monitoring. Someone raised monitoring, really critical, the AI that we deploy in our environment. But really, it's like an extension of what we're already doing, what you're already doing. So I just want to empower everyone that wherever you are in the maturity of the organization when it comes to AI, you already have the tools. And I think the most important thing we can do is just start thinking about like, what is our risk tolerance when it comes to AI, right? And for me, we got to be green when it comes to people. We got to be green when it comes to trust. And maybe we can afford to take a little bit more risk when it comes to, an uncertain regulatory environment or strategic risks.
Thank you so much, Melanie. I can't help but reflect on how close your response came to a very familiar feel to commas around this concept of back to basics. And certainly with the reluctance to oversimplify risk management, but reflecting on how, AI is a disruptor in healthcare. We've had other disruptors in our journey over the last 30 years, especially as nursing as a profession. I reflect on, when it was the best practice to make sure nurses were in the design of electronic medical records and health records. Some of these concepts around it is newer in that we're learning a lot about how to work with AI, but sometimes sticking to basics and doing what we've always done well is a really great place to start. So thanks a lot for that, Melanie. Okay, our next question is both for Kama and Ozzy. We'll start with you, Ozzy, if that's okay. Ozzy, how are you and we mitigating and managing risk of bias in AI data and AI algorithms today?
Great question. So many of us know that much of the guidelines we use today in our practices are based on these studies that were done historically in the Caucasian population. So things like the normal range of blood pressures, the clinical presentation of heart attack. Some of these things are studies that have been done in the past. And for many of our current clinical practice, these were, it's important to acknowledge that a lot of this grounding data comes from population studies that were done in traditionally Caucasian populations. And now more and more, we're moving towards adopting these studies in different populations and adjusting some of these current practice guidelines, normal ranges for various lab values now in different populations. But this is something that, is a more recent evolution in what we're doing now. But the medicine that we practice comes with some inherent bias already embedded in it. And this is the very data we're using to now train AI models. It's not, we're not inventing it from scratch. These are like guidelines that exist now that we're using for clinical practice, and we're leveraging these same guidelines in the AI models that we're building. So it's important to just be mindful of baked in bias that's already there in our current practice, and the fact that it'll just translate, and I'll be honest, amplify in AI models that are trained on similar data, similar ways of thinking. So the challenge then becomes, now that we know this, how do we test our models explicitly against this bias that we know is baked in? The other piece to keep in mind along the same concept of how do we test against it is that there's bias that we're not going to know ahead of time that's already baked in. And so when we don't know, we still have to explicitly test against things that we think are going to impose an element of bias and skew a model's performance. So the way to do it technically from a pragmatic perspective is there is specific data points that we collect, and we establish populations, and we test the performance of a model in these different populations. How you define a population varies based on the specific element of bias that you are thinking about. So gender, for example, is one, sex is another, and these ones are different in different populations that you would test against. A really cool example is that, in Canada, we don't systematically collect ethnicity data or race data. And we know that there are lots of, existing guidelines that are influenced by ethnicity and race, things like blood pressure management, for example. So being able to collect data, specifically these kinds of data that we may not have historically collected, with the intention of testing our models in these different populations, becomes really, really important to build a safety against propagating bias more broadly in our models.
Thanks so much, Azzy. Kama, having heard that from Azzy, what are some things that you're keeping in mind in the work that you're doing over at Trillium?
Yeah, I'm gonna double down on some of the pieces that Azzy has highlighted here. Just in some of the work that I'm leading, I've been doing environmental scans to find out what we're doing across the province related to sociodemographic data, how we collect it and for what purposes. And often I'm hearing we're using it for more reporting than for a clinical nature. And so I don't mean to be provocative in saying that, but just to offer a reflection that as we collect data points such as race, ethnicity, housing, finance, as you mentioned, a few others, the individual's identities and the data collection and the intention of data collection are really vital, because when we build and design models right from the start, they can really be biased. Or be, again, lacking the information to inform and therefore not be biased. So what some of the work that I've done here at Trillium Health Partners has included evaluation of models that we have turned on. And so it's important to know where these models are actually built as well. They can be American. And one of the examples of a project evaluation I conducted used a US-based naming algorithm to be able to infer race, ethnicity, because we have such an absence in our data sets. And so this is a common exercise that can take flight when we're, again, using a US-based algorithm. You're also comparing different ways of how we categorize, identify intersectionalities. These are important considerations. And so we used a confusion matrix to start to understand our patient population and see if there were any biases at play. And that's been useful and built into our ongoing monitoring systems. But I also want to share some reflections about how in leading this work, it always comes back to data collection and ownership of data. And so I want to pose the questions about who owns this data and whether or not we're working with our communities to engage about data ownership, agreements about data, and our obligations related to data. One of the principles from an ethics perspective I hold dear is non-maleficence, meaning non-harm. To do no harm comes before any other ethical principle when we think about data. You can have transparency about how a model performs, but we can inadvertently create harm by not understanding the data that we have and understanding, again, data sovereignty. And then, of course, perpetuate harm through the use of AI. So I really encourage those of you listening to think about how we collect data and how we engage our communities to do no harm.
It's a really great message, Kama. Thanks so much for sharing that. Melanie, the next question is one we hear often, certainly not just from nurses, but others in the healthcare sector, which is really this concept of AI going rogue on us and what that means for the healthcare sector. Maybe you could talk to us a little bit about what safeguards are currently in place or that organizations are putting together to try and really avoid that rogue future that's anticipated or feared.
Okay, yeah. So, I think AI is really scary for a lot of reasons. And it feels like quite existential when we think about misinformation or the impact of AI on elections, or the ability for my children to be able to think critically. Like, I find that really scary. But when it comes to healthcare, I actually feel much more confident that we are going to fare quite well when it comes to how we use AI. I think when it comes to the big buckets of risk, and I always toggle in my mind between four big buckets. There are more than just these four big buckets, but for me, the main ones are safety, privacy, like all things data and confidentiality related, equity, so bias, and that's already been spoken to a little bit. And then like what I call human capital, I need to rename it, but just like the impact on the human aspects of care and how our care teams function. So when it comes to all of those things, we're already quite highly regulated. We have like very well established processes and policies when it comes to, like, for example, privacy. Like, we already handle the most sensitive data you can handle. We have a whole piece of legislation just dedicated to privacy in healthcare. We are all very well schooled. So AI for us, it's not like a revolution, it's an evolution of things that we, like safeguards that we already have in place, right? Like safety, from a safety perspective, we already know how to track quality. We're oriented to data. We've kind of developed a safety science in healthcare. And when it comes to equity, I think, and for us, especially at Unity Health, like we really feel like we already are thinking about equity in a way that other sectors haven't baked in as much into their day-to-day work. But some of the safeguards that are really specific to AI, I would say, from a privacy perspective, just focusing on de-identification at source. Like a lot of what people worry about, we've done patient focus groups And when you say like, so what do you think about AI in healthcare? A lot of people are like, that sounds horrible. Like, I don't want you to know about me going to the emergency department for this highly sensitive thing. But when you explain, like, actually, we're stripping out your name and any, your birth date right from the start, and we're actually only interested in like what a million visits tells us about something. We're not interested in ever looking at your unique visit. You like with public education, I think even the privacy risk goes down, and the importance of de-identification at source is really emphasized. So I think that's really important. And I think if you can operate in a closed environment, and we're very attuned now to checking for like encryption and other security controls when it comes to deploying AI. We're more and more concerned, I think, about data sovereignty, like data only traveling and being at rest in Canada. So, hospitals are very attuned to that. I think, and also on the issue of data, I think one of the nice things that's happening as a side effect to AI is it's really forcing us to think about Indigenous data governance, and who makes decisions about the use of Indigenous data. So I think that all of those safeguards are either in place, or their development is being precipitated by AI. For safety, I think, silent testing is key. Like if there's one thing, it's just long, rigorous silent testing. It's almost like making a clinical trial out of it. And I think that's really the direction that we're moving into. And I would also highlight, like, I think we are deciding in Canada and in the EU and other jurisdictions that we're going to treat AI like other medical devices. And in healthcare, we have medical device regulation, and we are familiar with the concept of having a device be Health Canada approved. So I think we're going to start to think about it in that vein, with all of those kind of safeguards that go along with that, having those tools licensed. I find equity, like has already been discussed by Azzy, like it's challenging because we don't always collect the data that we need to test for bias and inequity. And I think back to, so at Unity, we've probably deployed more than 50 tools. We haven't live deployed all of them because sometimes during the silent testing, we pick things up. And there was one February where we were doing a silent test of a tool in the emergency department. And it was meant to just tell us, like, flag which patients just need a few minutes of physician time, and then they can be discharged so that they don't wait too long. And it was in the silent test, this is operating in the background. It's not influencing care, but it's generating a list, and many of the people on that list were homeless. Right. And it was the middle of February. It was freezing cold. It's like we didn't want to, but we don't collect data, right, on whether people are housed. And so we couldn't tell the algorithm, to catch that and stop doing that, because actually we want to keep them warm because the shelters are full. And but it's really interesting. Sometimes right now you need your eyes to act as a safeguard for inequities, because we don't always have all of the data that we need. And again, I hope that part of what happens is that this prompts us to just develop, more capacity to collect this data and analyze it, so that we are more sure, and that will just have knock-on effects for equity in healthcare in general.
That's really great, Melanie. Thanks so much for sharing that story. I got to say, I really love this because it's a perfect segue into my next question. It's an evolution and not a revolution. I think that's a really great tagline. It really speaks, comma, to how we are forced to evolve as a nursing profession, and how we use AI as a new tool in the care that we deliver. So my question to you, comma, is, as we reflect on a new cohort of nurses coming in and working alongside of us, how can we ensure that the AI tools that we use, not just for our new cohort, but also as we introduce to our seasoned nurses, that they complement the care that we get rather than replace the compassionate and human touch that is at the core of nursing work? What are your thoughts on that?
Thanks so much, Bren. So there's a concept called human in the loop. And for those that are not familiar with this, it's essentially as it's described. But imagine the AI spewts out a score. The score is translated in some mechanism that can be understood by the nurse. The nurse validates that, human in the loop, interprets it in terms of a clinical workflow, and then takes takes action or maybe doesn't take action. And an example of that might be an escalation. And so when we decide to use AI, we need to, as I think Melanie mentioned, identify the degree of risk the model presents. Is it adjunct? Is it informing the clinical decision making? Is it making a recommendation that is considered high risk? And I say that because I want to encourage you to think about what this means, as you said, for our new cohort of nurses coming in. We have to be careful that the systems are not designed to be over relied upon. AI does not replace critical thinking, if that's one message you take away from today. So what we know is that nursing knowledge is complex in terms of, remember, there's many ways of knowing. A great text about that. Sources of evidence that we use, relational, contextual, individual needs, population needs. The complexity is great. And so we need to design systems that support those complexities and rather navigate those complexities. The hope here is that AI is supporting a completion of tasks to enable the nurse to make decisions. It's another input and perhaps replaces less complex tasks, fingers crossed, so that nurses can perform higher cognitive tasks. Enables nurse to get back to what we envision as bedside nursing, patient care. There's a balance, right? So presencing, listening, storytelling, advocacy. These are incredibly beautiful facets of nursing that are not reflected in an algorithm, yeah? And so we can be deliberate to design for judgment, for the workflow, the right workflow, and to design to support compassion and humanity.
Love those messages, comma. Well said. Our next question here is for Azzy. So you heard comma talk a little bit about some of those competencies required in terms of understanding critical thinking and that it doesn't replace critical thinking. And so on that note, what education would you say nurses or others really need to use AI well in healthcare?
I'm actually going to also double down on Kama's comment in that AI does not replace critical thinking. I would go as far as saying the way AI tools are being developed right now for healthcare, they are meant to be tools, ways in which we could improve the way by which the efficiency by which we function and the accuracy by which we provide care. Which means that at the end, the ultimate decision maker remains the clinician, remains the bedside nurse, and whoever it is that's using the tool. And just like any tool, to be able to use it well and as intended with minimal harm associated to, be it bias from the model or poor performance, is understanding how it works. Bottom line, these models are probability calculators. The output you get from many of these models has to do with a best guess or a best probability of what it thinks the output is based on calculations that it does in the background. And what's really cool about it is that because it's a computer, it will consistently make the same calculation the same way over and over, irrespective of any other environmental effect on it, which is different to humans. But appreciating the fact that this is a probabilistic calculation allows us to appreciate that there is uncertainty in the output that you get from a model. And it then grounds us and prompts you to then think about how does a model's output actually relate to your patient? Because you as the clinician know the context of the patient. And if you understand how the model works, what kind of data it was trained on, you can decide whether a model's output actually relates to your patient. Many of these models are great at giving an output based on the data that it was trained on. So if it sees lots of patients with a particular type of heart attack, if you have a patient who has a similar pattern of behavior, it's going to be pretty good at predicting, yes, this patient is going to have a heart attack. But if you present to them a patient that has features that are different to the bulk of the data that this model has seen, it's not going to be good at predicting it. And you as the user, if you are well aware of this being a probability-based output and how it was trained and the specifics of what kinds of data it's seen, you will be empowered to be a perfect judge in determining whether the model's output actually relates to your patient. You are ultimately the expert and the clinician in that patient's care.
Thank you. Thanks for that. Our next question, I think, Azzy, if you could carry on that thought wave, what are your top recommendations on what we focus on to safely integrate AI into clinical workflows?
Yeah, so as we were talking about earlier in AI going down the same route of medical devices in healthcare having gone down, it is really important to make sure that particularly we as nursing get involved in making sure these solutions are designed not just for the right problem, but also that they have the right fit within existing workflows. What that means is that and like we do this in our lab, is that we get everybody involved to come and be part of the design process so that we can understand what the existing workflows are, identify inefficiencies, and figure out the best way to implement and integrate a model into an existing workflow, for example, to optimize the efficiency by which the entire task, for example, is done, and the accuracy by which the work is done. In getting involved is how you can really push to make sure these solutions are tailored for the actual clinical space for these models that are intended to be a part of, instead of most of them being developed what I call in vitro, which is in research labs far away from clinical spaces. These become tools that don't necessarily fit the intended purpose that they're supposed to serve. And so in that context, being engaged, getting involved becomes really, really important.
Thanks for that, Azzy. Kama, anything to add from your perspective on that question?
For sure. Let me try that again. Leaders can play a vital role here in ensuring that nurses are at the table for co-design. I believe strongly in shared governance models and nurses being at every single decision-making table. So as an example, at Trillium Health Partners, we have Terry, our Chief Nursing Executive, at the highest level, helping support AI decision-making, removing barriers, but also inviting ideation. And then we see this through to how we design AI for the future. So just last week, I made sure I triple checked that we had at least 4 nurses attending one of our design sessions with our AI partner. And so it's really exciting to see that happen, because I don't want to show up as a senior seasoned nurse influencing the day-to-day work of an emergency room nurse. I want the nurse who's actually impacted telling me about their current state workflow, just as Azzy described. And then thinking about councils and the role that whether it's interprofessional or nursing advisory councils play in decision-making and understanding data. And then I'll end with something that I believe is helpful to decision-making tables, which is guiding principles. So for example, are our outputs for AI purposeful in how we design? So please don't make interruptive, AI solutions, such as a pop-up, when that can be disruptive, especially if it's over alerting. Because that creates more work and escalations. Number 2, as I mentioned, keeping the human in the loop. That is essential here. Then, of course, understanding the output, as I mentioned earlier, in competencies. So the AI will give you a number. How does that get translated? Low, moderate, high risk, as an example. A visual in your electronic health record. And then lastly, the role of monitoring and mechanisms for reporting things that are risks. So bias, safety, concerns, things like that. So ensuring that nurses understand, again, principles related to safety.
Thanks so much, Kama. Melanie, just building off that a little bit, what is your opinion on how professional accountability can be maintained and even increased with the use of AI in all aspects of healthcare? Any thoughts on that?
Well, I think we are 3 for 3 that AI does not replace critical thinking, is the thing that you should take away from today. I thought that was brilliant. I jotted it down as soon as the first person said it. Um, so definitely the most important thing. And kind of what I've been saying all along is like it doesn't change as much as you think when you really boil it down to first principles. And I will say that, we don't have AI deployed yet where it's operating independently. Like we don't have autonomous AI. We have humans in the loop who are making the decision, but I think that it probably won't be long that there are these tools that people start suggesting. So I think like that's the next stage. But right now, AI is functioning as like an additional source of information. So we have that human in the loop, but again, we can't take too much comfort in thinking that a human in the loop is a fail-proof safeguards, because I think AI tends to lull us into this like sense of complacency and like, oh, this is the answer, like it's super intelligence, right? And so I think for that reason, AI literacy becomes really important. Like I think that's the new universal skill set that we need in healthcare, as this is going to become more and more ubiquitous. But I think essentially for now, AI is operating like a big fancy vital sign monitor. You remain responsible for collecting the information that's relevant to the clinical context, ascribing meaning to it given the actual clinical situation, and having it as something that's feeding into your professional judgment, based on your entire like knowledge, skill, and experience. When you think about like, well, sometimes people will ask me, well, like, what am I accountable for? What am I legally responsible for? So I think again, like same principles, but just extending them, which is, the hospital, like any other medical device, right? Like a ventilator, the hospital's responsible for choosing the right ventilator, for doing the due diligence, for making sure it's Health Canada licensed, for making sure it passes all of our IT security tests and all of that, ensuring that there's ongoing maintenance. Same thing for the hospitals. What the hospital's responsibility is going to be around AI. The manufacturer of the AI, like any other device manufacturer, is going to make sure that they have to let us know how it works and where it works well and not. But the clinician on the sharp end is responsible for, exercising your knowledge, skills, and experience in a way that a reasonably prudent nurse would, using AI as a data input to that. And so it's very similar to what we already have when you're interacting with any other medical device.
Yeah, I love that, Melanie. Listen, I took away ascribing meaning as one of the neatest things that you said there, because that is such a human thing to do, to be able to actually ascribe that meaning to the output of it, and that won't go away to keep everybody safe. So thank you so much for that. Kama, I'm really curious to know, you've been in this space for a while now, you've done a lot of work. And I know you're well connected to the work of AI and nursing outside of your own organization. Can you comment on what you see is the biggest disconnect between AI research, AI development, and more of the legal operational realities of the healthcare or nursing care environment?
Yeah, for sure. I want to quote our CNA president, Valerie Garcia, who recently did a post on LinkedIn and talked about how we can leave our profession vulnerable and put our patients at risk if we're not at the table. And that's paraphrasing something she recently said. And that was in the context of politics. And I want to apply it here just as much. In terms of nursing not being in the discourse. And, I started to study AI in 2019 because I felt that there was that absence of understanding us. There was a strong physician voice, physicians leading, and the impact. What we know from the research is that there are nurses that are doing invisible work. And so I urge you to look at that literature. We are the strongest segment of the health human resource, the workforce, essentially. And the absence of being thought of as we are an afterthought as opposed to being brought forward into the conversation And so a lot of my comments earlier have reflected the urgency to be at every single step of the AI pipeline at the different various levels within an organization. And outside of this is to please publish, please do research, think about the funding for research related to this work for nurses. And then, of course, if we don't do this, there will be assumptions about AI in healthcare that will not reflect nursing practice, our values and accountability, just as the title for this webinar for today. So again, I loved what you said, Melanie. Complacency was one of the words I thought of in the if we don't get at the table for decision making, and influence, policy. If we don't do the research to help influence, this will impact us heavily, and there will continue to be invisible work, and let the systems not define who we are as a profession.
Thank you, Kama. I thought of what we permit, we promote as a segue over to Melanie and the question around what then should governance structures maybe look like from a hospital perspective before we implement AI in clinical care?
Yeah, it's a great question. So I think one important thing is that every hospital should be adopting a framework, because it's hard to talk about AI in the abstract. But once you have a framework, and I think the framework should have like a life cycle approach. So, right from design into development or procurement, deployment, monitoring, like bake in an analysis that's across the lifespan that is risk-based, right? So what those 4 buckets of risk, I kind of think of them as I toggle through the life span, set out some key values. So I think having all of that in one framework, there are many of them out there. You can even like create your own by blending them all together. Just gives everybody a sense of how responsible AI is being done. And then you have like, you can start asking questions, and it's meant to be iterative. I think we get paralyzed in like, when do we actually like launch the policy or launch the framework? Because the space is evolving so rapidly. But I think so. I think it's helpful to come out with a framework. People will often talk about governance, but what they actually mean is like management and oversight of AI. And I think the magic actually happens quite close to the front line. So just having a committee structure where you're fostering an interdisciplinary approach. It has to be interdisciplinary. If it's not, you're doing it wrong. Like, to think that nurses wouldn't be at the table, I can't even conceive of such a thing. Like, you can only do responsible AI with all of the disciplines at the table. It's very complex work. It takes all of the brain power. So I think those are kind of the key things, is have that structure and have a framework.
That's great. Thanks so much, Melanie. I can't believe we've landed on our last question for this event. It's really been such a pleasure speaking with you all. And we're going to bring this back to patient outcomes. And I'll ask the same question to all 3 panelists, if we could ask you to reflect about a minute each. How will we know as a profession that AI has enhanced or improved healthcare? And I'm going to start here with Kama.
What a great question. Always bringing it back to the patient is essential in the work that we do. So I'll go back to something I mentioned earlier in terms of problem identification at the start of the pipeline. And so identifying key priority indicators at that time, thinking about the Institute for Healthcare and Improvement's quintuple aim of team experience, right? Our staff experience, our patient experience, health equity, population health, and of course, value. These are important considerations, and thinking about value is not just about cost. Did we really truly make it more efficient for the nurse so that they could do patient care? And with that, I just want to conversely answer that question to say, when we haven't met it, have we designed without nursing? Have we taken time away from patients that could be given to nurses? Have we created invisible work for nurses and added more tasks and system management, as Melanie was describing? So think about it on both sides of the coin.
Thanks so much, Kama. Azzy, what are your thoughts on the topic?
A great question, and I'm going to bring it back to where I started in the sense that, a lot of the care that we provide is not foolproof, and we're definitely still far from providing precision medicine or personalized healthcare. And I think the closer we move to providing truly tailored precision care for each patient is an indication of us moving in the right direction. And similarly, so if we can cut down on the number of adverse events or even harm that's caused as a consequence of our decision making, that kind of falls apart, because these adverse events, broadly speaking, are not single agent related. They tend to be system related issues. And I think AI plays a really good role in bringing together the system as a whole to function more efficiently. So if we can cut down on those numbers, to me, it's an indication that we're heading in the right direction.
You're just on mute, Bren.
A bit of over-reliance on technology there to behave as I would have expected it to. Thank you. Melanie, any final words on that topic to close us off?
The like day-to-day qualitative answer is, I know that AI is enhancing care when the clinicians are like running to the bedside in response to an alert that they're getting from an AI tool. So I think like we should absolutely be measuring the impact on care and have a clinical trial approach to things. But day to day, it's really important that your clinicians are engaged and believe in it. And so I think that is a really valuable data point.
Thank you so much. And with that, I'll turn it over to Terry to close us out.
Thank you so much, Bren. And wow, what a great conversation. This concludes the questions for our panelists. And I just want to extend a huge thank you to you, Kama, Azzy, and Melanie. And of course to you, Bren, for your moderation of this event. We're very, very grateful for your insights. And I think just a wonderful conversation of how nursing really needs to be at the forefront of leading this evolution, not revolution. And a huge thank you to our attendees for attending this third annual TAHSN Nursing Week event. And again, just a huge shout out to all of our nurses on the call as you embark on celebrating this nursing week. I'll hand it over to Robin to close us off for the day.
Thanks, Terry. Thanks to our amazing panelists. We would love the audience's feedback about this event and invite you to please take just a quick minute to complete a short survey that's been created. You'll find the link in the chat. And a reminder again that if you want to share this event with others, the recording will be available later this week on the TAHSN website. Thanks everyone for joining us today. Have a great rest of your day. And of course, a very happy nursing week to everyone. Take care.